Dr. Tongji, would you like to welcome
Yes, welcome to everybody. Thanks.
Everybody, yes.
Thanks, Stephen, and thanks, Daniel, for participating to this Hangout. We hope that students are following this session on their YouTube video system. And we will answer to some, there are not much questions, in fact, because they are chatting on direct. And they ask questions and they answer by themselves. And when you look on the chat, it's not too bad. But GB has selected some questions for this week that maybe you could answer, both of you, and that will be answered in live for the following students.
Okay.
Maybe you're going to start with the question concerning epidemiology and herd immunity, which is directed to Daniela.
Okay. The question that we have for the herd immunity is that can we apply the concept of herd immunity for hepatitis B vaccination? If yes, how and what does he need? If not, why not? Because the person who asked the question is running a campaign of hepatitis B in Pakistan. Yes.
It's the first condition to be able to apply herd immunity is that the disease must be disease transmitted from human to human with no reservoir. And this applies for hepatitis B. The only difficulty we have with hepatitis B is that, as you know, the difference with other viral diseases such as measles, for instance, when you are infected, you may become a chronic carrier. And if you become a chronic carrier, you will be a source of infection as long as you carry the virus, which may last for your own life. So even if we reach very high vaccine coverage in infants, there will be still the reservoir of all those who have been infected before being vaccinated, who will still contribute to transmission. So before the herd immunity can really work, we have either to cure all the people who are carrying the virus, and now we have some new drugs which are able to do that, or to wait for sufficient time until all those who have been already infected have died and will be replaced by new cohort of immunized children, and then herd immunity, yes, will apply.
Okay. So that's answered the question for the herd immunity. We have a question for Dr. Brown on the GMP topic of his lecture. The student were wondering if the issue of the manufacturers that having to adapt their disposition to match the risk without giving specific references. They asked it because what was implied by the word disposition and reference is not quite clear. If you could maybe elaborate on it a little bit more, please, Dr. Brown.
Yeah, I think there are several examples that I could give, but as I recall from the recording that we prepared originally, I had cited the example of polio and the manufacture of polio vaccine as a very good example of why we have GMP today, good manufacturing practice. And in that context, as you're aware, polio is a very particular public health issue on a worldwide basis, and obviously why there is so much interest in eradicating it. And in the case of polio, historically, companies who were manufacturing it, if we go back many tens of years now, they had an issue with respect to the original production process where the vaccine was not properly inactivated. And without going into lots of details, there were two main reasons for that. One, was that probably the quality control issues associated with checking that it was inactivated were not up to the job. And I think that was probably one side of it. And then the other side of it was that the actual production process itself was not sufficiently rigorous to ensure that all of the poliovirus in the preparation had been fully inactivated, or in other words, killed. And so the regrettable result of that is that some of the poliovirus was not killed, it was still active. And so when the vaccine was formulated, some of that live poliovirus got into some of the doses. And so some of the people who were vaccinated, unfortunately, did contract polio. So now if we go, so as I said, that's a particular issue, and I've probably used the word disposition in that context, because what manufacturers were subsequently obliged to do as a result of that case history was, on the one side, they had to beef up their bioanalytical techniques in order to be sure that they knew that they had a vaccine that was active or inactivated or whatever. They needed to understand it properly. But on the other side, the manufacturers also had to have the process under control in a manner that enabled them to know very clearly that they had inactivated and that they had overkill in that, so that there was absolutely no chance whatsoever of getting live poliovirus in one of the doses that you subsequently give to people. So when I said matching your dispositions, I guess what I meant is that the company would need to take actions to make sure that, one, they understood perfectly the manufacture of the vaccine, and two, that they were able to control it properly. So that's where I was coming from with that phrase. That's an example.
Okay, great. Thank you. And actually, we have a question for Dr. Lewis, but Dr. Lewis, we have some difficulty connecting him to the Hangout. I think, I'm sorry, it's my fault, but I think maybe Dr. Tongji can answer the question, because the student was wondering if the differences between the clinical trial between the phase 2B and 3, what is the clear difference between these two phases?
Yes, it's a good question, and in fact there is not much difference, except I think it's the number of volunteers. So phase 2B trial is supposed to be a phase 2, so it's an extension of phase 1 for safety determination on a large number of participants. And also in this phase 2, you are supposed, if you are in the phase 2B, you are supposed to address the efficacy of the vaccine. So you perform the phase 2B in a region where the pathogen you are tackling is endemic. Let's say for dengue, you will make a phase 2 dengue vaccine in Europe, phase 2A, just safety, addressing the safety. Then if you go in Asia or in Latin America, in endemic region, you will make a phase 2B, which will address the efficacy. And the phase 3 is also addressing the efficacy, but on a larger number of participants, maybe at least something like around 10,000 participants, maybe for some diseases, 10,000 participants per arm, which is a huge trial, which is obligatory done in several sites, maybe 5, 6, 7, or 10 sites. So the infrastructure is much more complicated. The price is much more high, of course. The cost of this such phase 3 is very expensive. So you prefer performing a phase 2B before, because if you have in the phase 2B an indication that your vaccine may be efficacious in endemic region, then you can invest the money needed for the large phase 3 that will also be in endemic region, but in broader areas. You will probably make a phase 3 in Asia and a phase 3 in Latin America simultaneously or sequentially.
Okay. Thank you, Dr. Tongji. And we have also the question from the clinical trial, because we know that the clinical trials takes a long time, but if there's any emergency outbreak like with the disease like Ebola, is there any changing in the process of clinical trial, and is there any phase that can be skipped because if we need it urgently? So if one would like to add to the question, please welcome. Yeah.
Yeah, so I can answer in the place of David Lewis. But yes, there are, of course, there are specific incentives to help going faster, depending on the emergency of the trial to be performed. But usually you have to ready to make the first safety trial, and you will not have any facilitation for this. Then, and this first safety trial has to be performed in the country where the vaccine has been manufactured. So in the case of an emergency, this emergency usually takes place in a remote country where the vaccine has not been manufactured. So you depend on the first delay of testing the vaccine in the country, in the manufacturing country, and this may take some months, some weeks or some months. Then this is very difficult to discuss because depending on the infection and depending on the emergency, it is very difficult to go for a phase 2 directly in the field because you need to have specific arrangements in order not to be suspected to test a European vaccine in a field in Africa, for example, if you talk of Ebola. That was the case recently because of the emergency. Some vaccines that have been manufactured in Europe have been tested in Liberia or in Western Africa during the Ebola crisis, and this might have been suspected of some problems because the vaccine has been only tested in a small number of volunteers in Europe, particularly for the VSV Ebola vaccine. And then it has been tested directly in the phase 2 in the field, in a re-vaccination test because of the emergency. But the safety test was not completely achieved. And as I have recently heard, some problems may have appeared during this test in Africa with this vaccine, which is not known to be completely safe for humans. So, okay, you can have some incentives, some help to accelerate the trials in the field in the case of an emergency, but we have to be very cautious on that because that may either give bad perception of the trials and close this country to next future trials for any other vaccine, or also that can lead to safety events linked to the too fast testing of the vaccine. This is my answer, but maybe Daniel, you have another idea to add to that discussion.
No, I think you answer perfectly the issue.
Okay, and Dr. Levibro, and so again with the hepatitis B, is there any model that can help support his campaign in Pakistan?
It's difficult to answer because I'm not very much aware of the characteristics of the strategy which is in place in Pakistan. There have been, of course, some modeling which has been done prior to the recommendation of universal vaccination, which have shown the very high benefit of routine immunization when compared to selective vaccination. Selective means only immunizing those who are at high risk. And based on this model, WHO made the recommendation of universal vaccination, depending on the country, either newborn or infants or adolescent, but in all countries with very high carriage rate in pregnant mother. The model have shown that definitively immunizing infant or even newborn is the best strategy, both in terms of effectiveness, impact, and cost effectiveness. And we have now some experiences from many countries over the world who has embarked on such strategies, which show that it works very well. And we have already some result, even in terms of cancer prevention, because one of the difficulties with hepatitis B vaccination is the fact that when you immunize children, it may take a long time before you can really prove the impact of hepatitis B vaccination, because the hepatitis B burden is mainly due to late complication of the infection. But we were happily surprised to see that even in a few years, in such places like Taiwan, it was already possible to show the impact of the routine infant immunization on the incidence of cancer, although liver cancer in children is a rare disease. The impact of the vaccine was so great that even in a few years, before waiting for the time needed to see the impact in adults, even in a few years, we could already see the impact in children, although the disease being very rare. So there are models. Models are theoretical, but there are now better data than model, which is epidemiological data from real life, which show that if you reach a high coverage in infants, you will have a tremendous impact on both infection rate and mostly on the epidemiological consequences of the infection, which is mainly the liver damages.
Thank you. And I think there's another GMP topic. So is there any standard for GMP for different country and a different region? Do we have to have all the GMP standard the same in every region, or how they produce the vaccine?
Well, I think ideally you would have GMP that's the same just everywhere if you could, because it would just avoid errors, it would avoid problems of understanding between companies, between regulatory authorities and users and so on. However, I think in practice that we are really quite some way from that. There have, however, been quite a lot of effort. A lot of efforts have been made to standardize GMPs between different organizations and different country blocks. I can illustrate that by quoting US CGMPs, American GMPs, and then European GMPs. There's a lot of similarities between them. A lot of their expectations are the same. It's just the way that they document, the way they write those expectations are not at all the same. And that's what makes things complicated. And then you have what I would call quasi-national international organizations, such as the Pharmaceutical Inspection Convention, the PICS, that many countries in the world are now members of. They have their own GMP. That's a sort of inspector's GMP. It's an international standard reference. And that is getting pretty close to something that's accepted on an international basis, particularly when you look at the fact that quite recently, I think it was last year, the Americans, the USA, actually also became a member. So that did help to improve international interpretation of what a standardized GMP means. But it's really far from being a reality today. There are differences between countries, regions.
Okay. Okay, great. I think we are pretty much out. I answer all the questions that I collected from the discussion board. Dr. Tanji, would you like to close the session for today?
Yes, this is easy to do. I'd like to also tell to the follower that they have to participate to the Hangouts if they want their questions being answered by the teachers of the MOOC. So this is one thing interesting to chat together, to ask questions, and to hope that the other attendants will answer the questions. And sometimes it's a nice way for the discussion, for the chatting. But you need also to have the answers given by the lecturers, and for that you need either to assist to these Hangouts or even to participate if you want, and also to the week before to prepare your questions and to ask them in a single bulk question that could be retrieved by GB to that. So what is the could you tell us, GB, what is the next week, this week that started just today? The program, I don't remember this is the week 3, not the week 4.
Next will be the week 4, which is and also I would like to say too that the fun platform has some technical difficulty as well, and that the access is a bit slow, and then we cannot access on the courses on Saturday. So I'm sorry about that.
That was last Saturday, but now it's okay. Everything
now it's working again.
It works. Okay.
Yes. So I would like to thank you, all our instructor, and thank you so much for participating today. We have some viewers showing that they were watching on YouTube and Google+. So thank you again for answering all the questions, and hope you have a good day. Thank you.
Thank you.
Okay, thank you all of you both, Daniel and Stephen, and see you next time in March.
Bye-bye.
Yeah.
Okay.